book dedicated to orbital fractures, their management and concepts, and has co-authored a book on ocular adnexal lesions. Over to you, sir. It might be late night in Singapore now, I think.
You're not audible, sir. I think it's still
Yeah,
muted.
sorry, can you hear me now?
Yeah.
Yes.
Okay, let me get the slides up. Thank you, Dr. Gunjan, for your kind invitation. I'll try to do justice, try to match some of the great speakers that we had before, Kasturi, Dr. Allen, and Bob. I think you've chosen wonderful faculty of speakers from each of whom I have learned over the years and continue to introduce into my practice. So one of the recent innovations is what I thought I should talk about, and I think Kasturi gave a beautiful treatise to all the various innovations in orbital surgery, and this is touching base on some imaging concepts in orbitofacial surgery. We all know that orbitofacial disorders can be challenging, yet when managed very well can be very rewarding. We often learn to work in teams, and that's where the craniomaxillofacial surgeons, the head and neck surgeons, and neurosurgery teams that we work with have really enabled us to do more for our children and adults. And amongst the various innovations, right now we're even talking about virtual reality and augmented reality, is actually simple concepts of imaging that we have been overlooking for the past 10, 20, 30 years. These are my disclosures, but more importantly, I would like to acknowledge my wonderful team over here, Dr. Blanche Lim over here, my two fellows operating while we're just observing and guiding them through, and compliments to these guys. They're the ones who stimulate us to do more. So when you look at imaging in particular, we used to talk about X-rays in the past, in the pre-80s era. That's when the CT scans really came in, and that's where the various spiral CTs and multi-disc detector CTs really came in, and they were actually fan beam CTs. We moved away from 3 millimeter cuts to less than 1 millimeter cuts, the IGS protocol, and now we no longer use films, but we use DICOM data. And every once in a while for orbital trauma and other conditions, we do use MRI as well. We are starting to use more and more intraoperative and postoperative CTs as well. But if you look at these images, for example, these are the images of a fracture, for example, with a conventional multi-detector CT. And these are the images actually you're now looking at it from a cone beam CT scan. And that's what we're going to be talking about today. So what exactly is a cone beam CT? Cone beam CT is nothing but a C-arm that has always been used in orthopedic and a few other conditions as well, where we are actually measuring volume of data in one go, like a burst that comes from a emitter and capture an image. And this can be actually captured anywhere from 200 to 300, even up to 360-degree plane. And the advantage of that is it catches real time within 30 to 40 seconds the entire panographic view of the facial skeleton, which is what we use. And we started using it from our dentists, the National University Center for Oral Health, where they have it in the clinic where the patients, children, adults just sit in the chair, takes 30 seconds to gather the data, and the DICOM data is what we end up using it. And it works on the concept of LRF principle, which means that radiation that is required to capture the information that we need as low as reasonably acceptable. And this volumetric data is what practically is being used in the C-arms and hybrid OTs and angio-seats. In other words, all of you are kind of exposed to this in multi-specialty hospitals where we actually have this technology. So this has really found its big way in dentistry. It has completely replaced the orthophantomogram that we used to do in the past. ENT is using it a lot nowadays. Orthopedics is using it for moving away from conventional CT to weight-bearing CTs as well. Interventional radiological procedures are being guided now by cone beam CT scan. Radiotherapy, which guided is also cone beam CT, and even mammography at this point of time. And that's what we're really talking about in orbitofacial surgery. The big advantage of using cone beam CT scan is it almost is up to 90% less radiation than the conventional CT scan. You know, ionizing radiation is a bad word, and every time a CT versus MRI debate always comes about, especially in patients with germline mutations and few other conditions. We don't like ionizing radiation. These machines are very compact and very mobile. They're very inexpensive, so to speak, short image acquisition times. In fact, patients walk in and walk out without any scheduled appointment, can be added on to any C-arm technology that we have. And when you're really looking at bony pathology, we can get whatever information we want. But there are a few limitations. That includes the details of soft tissue. But if you're looking at bony details, you're actually able to get it. And if you're going to be using radio opaque implants, you actually, again, you can use cone beam CTs to assess the postoperative positioning of these implants, whether they're well placed or not. And I'm going to share our experience with some of these in various indications. So these are some examples I'm going to be sharing about, and we've been probably using this for the past, since the COVID time, so to speak, for the past 2 to 2.5 years. So case number one is a patient who's got a classic inferior wall blowout fracture. You can see a conventional S-shaped curve to the floor of the orbit compared to the broken orbit as well with herniation of the contents. This is a conventional multi-detector CT where a postoperative reconstruction has been done. You don't really see the implant, but if you look at it, that particular straight line that you see over here is actually a bioresorbable implant, which you're able to capture it, whereby we have now done a reconstruction with very low ionizing radiation to capture good postoperative correction of an orbital fracture. Likewise, another case of a panfacial fracture, and I say panfacial, by our practical classification of fractures is upper, middle, and lower facial skeleton, which has been repaired. And we thought we did a good job, but if you look at a patient had postoperative inophthalmos and realize that actually the bioresorbable implant was placed well below the posterior ledge, hence warranting or justifying a repeat surgery. And like Kasturi had mentioned, here is a patient where we started using a PSI implant. This is a true match implant that we use, where we have gone back to redo the surgery in an accurate way, used a cone beam CT scan to look at the position of the implant even intraoperatively, so that you finish the surgery confidently knowing that you've done a good job. You can even do volumetric analysis for these patients, how you have reduced the volume from 34, 35 cc's to 31 cc's by good correction with the patient-specific implant, which is nearly comparable to the volume of the orbit on the other side itself. What are the other applications that we end up using cone beam CTs for? We use it for periorbital tumors, assessing extent and location of a postoperative orbital decompressions, assessing bony deformities in patients with challenging anophthalmic sockets, and even dacrocystography. Here's an example of a 3-4-year-old child who actually had a periorbital lesion, a classic dermoid cyst, so to speak, but we always worry whether it's an intracranial extension. This is a cone beam CT. This child goes, sits in the machine. Within 30 seconds, the image is acquired. And you can see the beautiful bony depression that you see. But what it also shows is a through and through from into the orbit itself. And if you have an intracranial extension, that should be also be seen as well. So with this confidence now with the cone beam CT, again, no sedation whatsoever, child sitting in the seat for 30 seconds, we're able to plan the surgery, go ahead, excise it as you can see over here. These are examples of patients who have a bad anophthalmic socket correction, and you wonder what's going on. Traditionally, we used to send them for CT scan and MRIs to look at what implants you have. But here you can see a 16mm implant in a patient who had a retinoblastoma enucleated by an ophthalmologist as a child, where again using low dose ionizing radiation therapy to assess not only the size of the implant but the location of the implant. Another patient who had multiple anophthalmic socket reconstructions, who said, yes, I have an implant inside, and you actually realize there's no implant inside, but just a classical eye inside. How about using it in patients with lacrimal drainage disorders? This is a patient who had a failed dacrocystogramnostomy, as you can see over here. And a dacrocystogram now shows that the exact location of the patency of the nasal lacrimal duct or the nasal sac. And you can see where the ostium site was and nothing beyond that. So you now know that that's exactly where the obstruction is, the scar tissue is. So you can do a dedicated revision PCR without any problems at all. How about patients with thyroid eye disease? These are very common, and we all are guilty of not adequately decompressing these orbits, or sometimes we over decompress these orbits so much so that we actually tear the dura of the temporal lobe or the skull base, causing CSF leaks with complications as well. So I'm a strong believer that every time you do an orbital reconstruction or you do an orbital decompression, be the surgeon who's bold enough to do a postoperative imaging to assess how adequately you have done. And as you can see over here, the preoperative multi-detector CT and the postoperative cone beam CT giving you the extent of decompression up to the tip of the temporal lobe of the brain. The lateral wall has been removed here, the deep lateral wall has been removed here, showing a good balanced decompression as planned more on the left side than the right side, giving confirmation of what you had planned earlier on itself. So we looked at our own data. We have about 25 patients so far till date, courtesy of Emmanuel Lee, our current fellow at this point of time, where we're looking at the demographics, the vast majority of men, being most of them are trauma etiology, but there are enough amount of women who have various other pathologies that we treat with. Most oftentimes, we end up using it for postoperative confirmation of good decompression or good reconstruction so far. But we also use it for preoperative situations in certain conditions itself. The vast majority of the patients, as you can see over here, again, it's all for fractures, but you do have a significant proportion of patients who use for thyroid disease patients and bacteriology patients, and a smaller group of oncological and EN and ophthalmic patients as well. And the indication, prime indication for cone beam CT scan is mainly for postoperative confirmation. And that's similar to the postoperative refraction if you do refractive surgery, ensuring even if the patient doesn't complain that you've done a good job, and a slew of other indications as well. So when you look at cone beam CT scan as well, and we look at radiological imaging criteria from our clinicians, we are just fixated on CT scan, MRI, so on and so forth. The requirements for radiologists is very different from the requirement for the surgeons and the patients. From a radiologist perspective, they want to be accurate. They want to be very complete in the diagnosis. They really need to see all the various details if you want. But as a surgeon, as a clinician ordering these investigations, all you want is just enough medical information for you to make a diagnosis, do a treatment planning and surgery. But do we really consider what the patients really want? What patients want is not just a diagnosis and management, but they also want to reduce costs and radiation exposure so that we don't cause any antigen damage. So in summary, I think cone beam CT is something which has been there for about 20, 30 years, but only now really being reinvented in our orbital-facial surgery, where we think it either can be a complement or an alternative for diagnosing management of not just orbital fractures, but a few other orbital-facial disorders. We are moving away not just from pre-operative diagnosis alone, but including intraoperative imaging and navigation and post-operative confirmation imaging. And with modern algorithms, we may be able to reduce the radiation exposure even more, avoid and minimize artifacts so that we can increase yield. So the volumetric data is also giving you a good representation of the adequate reconstruction. Thank you very much once again, and I'd like to compliment my team who actually stimulate me to do more and more in this field of orbital facial disorders, and compliments to all the speakers, and thanks to Ashok Grover and Dr. Andeep Bajaj, the team. Yeah, it is.
Thank you, Ganga. Always a joy listening to you. So this cone beam CT that you use, how much is the radiation compared to a conventional CT? And do you always take digital images only, no films?
Absolutely right. Yes, it probably is now only about 10 to 15% of the ionizing radiation exposure dose compared to a conventional CT scan. And when I talk about conventional CT scan, it's not even an IGS protocol sub-millimeter or 0.6 millimeter CT scan, even the so-called 3 millimeter scan, because the spiral CT does a continuous excision. And even the 3 millimeter cuts they were giving, actually they're acquiring all the images, but only giving us 3 millimeter cuts. And that's limited by the number of films they have to print, which is a cost to the scan for the patients. Now these DICOM data being burned as CTs, we completely eliminated the films. We are getting the exact data that we want from most of the bone anatomy.
So you would use them for the more difficult cases of, say, multiple fractures rather than for the simpler ones?
Actually, not really. I mean, we still go to the conventional CT for most of the fractures in terms of where you're going to be planning navigation. You want to assess soft tissue, you want to look at the muscles, you want to look at the fat. But if you're going to do it for the navigation purposes alone, we all
intraoperatively particularly, yeah.
Yeah, intraoperatively, yes. When you're doing revision surgeries, you're right. Yeah, when doing PSIs and all this, the stakes are very high. You don't get a third chance to go back in. Those are situations where we do intraoperative. That's right.
Thank you.
So as there are no further questions, we'd like to move to the next speaker. Our next speaker is